Perfect. Thank you, Pam. All right. Welcome, everyone, and thank you for being with us for our webinar, The Psychosocial Impact of COVID, Recognizing Family Dynamics and How They Impact Patients. My name is Martha Alvarado. I am the Manager of Online Education and Evaluation for MCN. And presenting today is Dr. Cato Weingarten. Dr. Weingarten is a clinical... Doctor, if you guys could please mute if you're not speaking, then thank you. Dr. Weingarten is a clinical and community psychologist who has worked with families affected by illness for over 50 years. She was an associate clinical professor of psychology at Harvard Medical School from 1981 to 2017. Dr. Weingarten has published over 100 articles and 7 books, many of which address the issues she will be discussing with us today. She created the Witness to Witness program 5 years ago and joined MCN 3 years ago this month. Thank you for being with us, Dr. Weingarten.
Thank you.
We're going to go ahead and go to the next slide, Kari. If I can get mine to go. And I quickly want to go over a conflict of interest disclosure. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose products or services are related to pertinent therapeutic areas. Next slide. And quickly, we are offering simultaneous interpretation for this presentation. So if you go to your Zoom toolbar on the interpretation icon that looks like a globe, you can simply click it and select the language that you want to listen in. At the same time, we have this presentation available to view in Spanish and English, so you can select which presentation you want to view as well. Next slide. And once again, welcome to our presentation from Migrant Clinicians Network. Our mission is to create practical solutions at the intersection of vulnerability, migration, and health. And we envision a world based on health, justice, and equity, where migration is never an impediment to well-being. Next slide. And our work, we do a lot of resource development, and as our comic books and other things, we provide a ton of education. We do some research. We do bridge case management through our health network program. We have a very robust worker health and safety program. We also provide support for provider well-being. We do a lot of advocacy and also peer networking. Next slide. Can you guys please put yourselves on mute? Thank you very much. MCN's primary constituents, the primary care providers, community health workers, nurses, dentists, social workers, outreach workers, public health professionals, health educators, medical assistants, and many others. And we work with underserved migrants and immigrants. We work with clinicians, migrant and community health centers, and also we work closely with state and local health departments. Next slide. And again, our presenter, Dr. Cato Weingarten, founder and director of the Witness to Witness program, associate clinical professor. And as you see in the picture, one of her books, Common Shock, Witnessing Violence Every Day, how we are harmed and how we can heal. Next slide. And okay, Dr. Weingarten, please take it away.
Thank you, Martha. So one of the things, and it doesn't show on this slide, but we are simultaneously serving people who are dealing with COVID, but of course that doesn't exempt us. So at the Witness to Witness program, we really encourage people who take our webinars to consider double listening. And by that, what we mean is listen for yourself, because you are likely a member of a family, but also listen in your professional role in terms of those people you serve. And here, this is just a kind of a classic picture of the SARS-CoV-2 virus, and the name of the disease in shorthand is COVID-19. Next. These are some numbers, they always are shocking. I'll let you look at these for a moment. Next slide. And here again, this is something that all of us on this webinar, I'm sure we know very well. There are structural and determinants of health that have an impact on us as sort of individual, bodies moving around in space. Our lifestyle factors have an impact, the communities we live in, and the sort of general socioeconomic, cultural, and environmental conditions. And these conditions affect us in many, many ways. Next slide. But when we look kind of in a more coned down, zeroing in fashion, we can see that there are a number of very particular structural inequities that impact us in terms of our experience of living with and living with people with COVID-19 and its sequelae. Next slide. So again, we're going to look a little bit more closely at just one group of workers who you may work with, serve in your professional lives, and you.
Kata, Kata, we lost, I hate to interrupt you, but on my end, we lost your sound. I don't know if anybody else is having that problem.
I don't.
Oh, there you are. Now you're back.
Okay, so strange. Did you hear the introduction to this slide?
We did, yes.
Okay. So I was just saying that you may work with people who are essential workers, or you may consider yourself an essential worker. There are certain conditions of work as an essential worker, and interestingly, healthcare workers not on this list, but we know healthcare workers are and were during the pandemic essential. But these are factors: the lack of PPE, lack of paid sick leave, limited access to testing, and limitations in relation to housing and transportation. And all of these factors have an impact on how the experience of COVID-19 plays out for the individual and family members, and of course, the work setting. Next. And then we can look even more with a close-up lens, and we see that there are very particular, what we call enhanced vulnerabilities: low wages, living in a rural area, and I'm going to come back to that one, a migratory lifestyle. You can read these: crowded housing. These are all things that people we serve deal with when they are trying to cope with initial experiences of COVID-19, and then subsequently, as we will see, with long COVID. Next slide. So this is pretty straightforward. We think of COVID and how it impacts a family through the body-mind, not just the body and not just the mind. Next slide. And I'm going to go through, I want to sort of, if I can, take these one by one, because a COVID scenario really does unfold in a particular way, and people have lots of questions. So the first one might be, is this person truly sick? And if so, what do they have? Is this the flu? Is this a cold? Is this RSVP? What is RSV? What is going on? Next. So, okay, should I get a COVID test? And if so, where and what kind? Then you have to have, where are you going to find a test? And then you have to wait for results. And all of this can be really confusing. And then the scenario unfolds further. Next point. So what do you do during the waiting time? If it's a rapid test, it could be 15 minutes, but if you took a PCR test, it could be 48 hours. And what do? Do you go to work? Do you send a child to school? These are all confusing questions that people have. Next. Okay, so if you test positive, well, can you actually isolate? Or if you're an adult, you've got decisions to make. Should I go to work? Should I tell my employer? Do I need childcare? What do I do about sending a child to school? If I have parents I'm taking care of, what do I do about them? Next point. How do you isolate a child? What if your 4-year-old gets sick? Do you put them in a room by themselves and give them food, through the door? What if there's no private space at all in your house? Who's going to take care of the child? Again, these are all confusing and pretty common scenarios that unfold. Next. Even this seemingly simple distinction, we learned, some of us, 2 different words: quarantine and isolation. Frankly, I've had difficulty myself keeping them straight. And I finally realized that the word isolation begins with an I, and you separate ill persons who have a communicable disease, and that ill starts with I. So that's a little trick that I've used to help myself, because I do find this distinction, which is a very important one in figuring out what to do, still hard to take in. Next. And then we had to learn very specific signs and symptoms of COVID-19. And of course, not everybody has all of these, and some of these co-occur with other illnesses like flu. Next slide. And when is sick too sick for school? And again, I'm trying to point out that all of us find these kinds of decisions that we are having to make confusing and challenging and not straightforward. You can see, and even with this little kind of graphic, somebody might say, well, I'm not sure if it's in this column or that column. These are not straightforward decisions that we've all had to learn how to make. Next slide. So the COVID scenario continues. So we have to quickly learn what to do. If somebody in our family tests positive for COVID, of course, we need to treat for comfort, but we also have to monitor for serious illness. And in some families, they have never had to do that. They don't really know how to look for and make a determination as to whether something is progressing in an uncomfortable but manageable at home course, or whether it's turning into a more serious illness. Next. So when to call your primary care provider? When do you go to urgent care? When do you go to the emergency department? These are decisions that families have had to make over the course of the last 3 years, and none of them is easy. Next. Well, what if the person has underlying medical issues? Which ones matter? And we know that over the last 3 years, the scientific answers on this question have changed. So again, the science is not a stable point, it's a moving target. And that makes answering this kind of question that arises quite challenging for families. Next. And does the person qualify for a treatment? Now let's just take the treatment Paxlovid. In the last 12 months, I have probably heard 50 different stories of people who tried to get Paxlovid and had a range of responses from providers. And the reason is that, again, this is not a clear, fixed science. Different locations have different availability of Paxlovid, as well as some of the other treatments that have been available and now also not available. For instance, in the case of Evusheld, which was available for about a year for people with serious immune compromise, and now it's been decided that it really doesn't have value and it's no longer available. So again, the science is changing and it's confusing for people. Next. So if you happen to be somebody who qualifies for Paxlovid, it is highly recommended that you start treatment within the first 5 days. And again, depending on where you live, this can be impossible or extremely difficult. Next. And then here's a whole other can of worms. What if a family member doesn't even believe that COVID exists, and yet they are showing signs of a COVID infection? What do families do? And we know that they really struggle with this. And each family struggles a little bit different. And the outcomes of each family's struggle are a little bit different. Next. So we also know that COVID has a differential impact depending on which family member gets sick. And although COVID has more serious outcomes at a population level for people over 65, it certainly does strike elders, adults, teenagers, and even children. Next slide. What this slide is showing us is that from 2021 to 2022, deaths from COVID-19 in children and youth was approximately ranked number 8 in the leading cause of death. So this is a really concerning disease for many children and youth. And in some areas, as we know, as you know, people don't have the idea that COVID can ever be serious for children. And that is just not the case. It is and can be serious for some children and youth. Next. So again, we're kind of going to look at, well, what are some of the locations in the body where COVID can have an impact? And there are many different graphical representations of this. So here we see it can affect the heart, the brain, the spleen, the liver, our blood vessels, the gastrointestinal tract, the kidney, the pancreas, and the lungs. Next. So let's look for a moment at something that we've learned about the experience of family members if they had a family member in the ICU. It turns out that a patient who was in the ICU, but also that person's family member, could develop post-traumatic stress syndrome from having been in an ICU trying to survive a COVID infection. Next. And going back to the question of the social determinants of COVID-19, in this case, mortality, in one study, they found that in rural counties with more non-English speaking households and more farm workers, there were significantly higher levels of mortality. And that was also true for counties with higher levels of poverty and more residents over the age of 65. So sometimes these factors cluster, and we see that the people, the families that are going to be dealing with more loss, more death, and more grief are likely to be in our rural counties. And as we know, mental health services are fewer in those counties that might in fact need services the most. Next slide. So many of the families we see that we serve are dealing with grief. And it's important, I think, and I really like this slide because it shows us that grief isn't just sadness, but it can be a tangle of many kinds of emotions, from rage and depression, confusion, anxiety, bitterness. Lots of feelings can be tangled up in our grief. And grief on one day in 1 hour might be really different from what grief is at another time. Next. Living with grief, and again, we kind of look at this body-mind figure where our body has an impact on our psychology or our emotions, and our emotions have an impact on our body, on our biological condition. Living with grief, there are going to be, likely can be, disturbances of our sleep, our appetite, our energy level, our mood, even our dreams can be impacted by grief. And as I'm sure you all know from not just your professional experience, but your personal family lives, in families, when one person is deeply grieving and another person has a different way of coping with their grief, that can often produce conflict that's difficult to name and deal with. Next. So again, we have people who have been hospitalized with COVID, released from the hospital, and then some people, and we're going to look at percentages in a moment, may be dealing with the after effects of COVID, now called long COVID. So in the hospital, somebody might say, I feel terrible. I'm not myself. I don't know who I am. I can't stand this. But they may not only be met with sympathy, because people might have said, well, you should have worn a mask, or you shouldn't have gone to that concert. You shouldn't have done this. You should have done that. So it's not even so clear that somebody who develops COVID and has a terrible experience in the hospital, meaning they feel terrible, not that they were treated in a terrible way or received terrible treatment, doesn't necessarily come out of the hospital and everybody is purely and only supportive and compassionate and caring. Sometimes the person gets blamed. Next slide. And here we have a kind of a diagram, a flow chart, you might say, of what the course can be. So starting from the top left, you can have an acute COVID-19 experience, and 5-6 days later, you make a full recovery. That's great. That's what we hope happens for everybody. But for some people, they will develop long COVID. And here we're going to see one graphic illustration of what the proposed contributing mechanisms are. And we're going to see another in a moment. And of course, some people over time will make a full recovery even from long COVID. That will happen for some people. Next slide. Interestingly, or sadly, there's no list of long COVID symptoms that are the same by everyone who is making those lists. And I think it's interesting that here's just a sample, but nonetheless, we have the University of Missouri who identifies 7, and then you have the CDC in their list of long COVID symptoms, it's 19. In Yale, it's 22. So here are the items, the list of long COVID symptoms that the University of Missouri identifies: a fast beating heart, hair loss, fatigue, chest pain, shortness of breath, joint pain, and obesity. And I will bet that there are people on this call, on this webinar, who have right now are thinking about names of other symptoms that you associate with long COVID. Maybe we'll just take a moment and have you enter that into the chat, and Pam will let me know just a few of the names of what you are entering into the chat as other names for long COVID symptoms.
They're coming in quickly. So we have muscle pain, brain fog, persistent cough, brain fog, ongoing cough, in Spanish, depresión crónica, memory loss, memory issues.
Yeah, so you can see, I mean, your own personal kind of catalog, you might say, of the names for long COVID symptoms is different from this one. And I'm going to make a point again that this makes the situation very confusing. Next. So approximately, and we're going to see a different number in a moment, 1 in 5 adults ages 18 and over have a health condition that might, not is, but might be related to a previous COVID-19 infection. And here these are 6, not the 19 symptom list, but these are sort of areas: neurological and mental health, kidney failure, musculoskeletal conditions, blood clots and vascular issues, respiratory conditions, and cardiovascular conditions. And it'd be kind of interesting to know for the people who entered symptom names into the chat, whether these 6 categories cover all the bases of what was listed. Next slide. So again, I'm going to make this point. The fact that there is no universal definition of what constitutes long COVID or a lingering response to a COVID infection makes it very difficult for both the individual and family members. Next. There are not that many specialized services yet. Next. And although we wish that this were not the case, of course, because there's no clear definition, it does happen that a person who has lingering symptoms can easily be met with skepticism by a healthcare worker or a family member, or just with frustration because there's no clarity about what to do. And we are going to talk about the role of vaccination in a moment. Next. And of course, even if there are services available, if you live near a center that has a long COVID program, there are very long wait times, and people don't know what to do in the interim. There's not much good advice. Next. Here are, or this is, a graphic representation of ways of thinking about sort of 4 now, not 6, as in the CDC diagram, long COVID conditions, the way it shows up. There can be thought, mood, and sleep disorders, a dysregulation of the autonomic nervous system, pain syndromes, and exercise intolerance and fatigue as an outgrowth of even as minor a movement as, you know, walking from the bed to the bathroom. Next slide. And here, when people with what they thought was long COVID were given a cognitive functioning scale, you see that about half of people who presented to a hospital system because they did feel that they were having symptoms that were like brain fog or memory problems. About 48% had either no dysfunction or mild once they were tested, but about 52% actually had moderate to severe dysfunction. Next slide. And this most recent statistic where we're looking at, well, how many Americans are out of the workforce due to long COVID that has been diagnosed by a medical provider. At the moment, and this is a pretty recent, this is about last week, I think, at the beginning of last week, there were about 2 to 4 million Americans out of the workforce. Okay, next slide. And again, this is another graphical representation of the hypothesized mechanisms. And you can see, and one of the reasons why I present a number of these is because it's confusing. And over time, we've had different representations, different understanding of what those underlying mechanisms are. And when you have a change in the hypothesized mechanism, of course, you have a change of who's going to be found to qualify for a long COVID diagnosis and who is not. Next. So let's just look at the mental health burden and the way it impacts families. So you have somebody who's now got their sleeping and waking cycle is, let's just say, mixed up. Now, of course, that's going to have an impact on family. If you have somebody who is walking around at night and trying to get things done because their sleep cycle is has been altered. That has an impact on family. Next. People with long COVID can have more anxiety and more fear-related disorders. Next. As I've said, they can have a traumatic response and stress-related disorders. And of course, that has an impact, as does anxiety and fear, on their interactions with family members. Next. And people, try to help themselves. And what we see is that there's been an increased use of all kinds of medications to manage the mental health experience that people have of COVID. But also, I think we have seen caregivers have also used more medications to manage their experience of having a family member with long COVID. And I'm going to be talking in a moment about ways of understanding the caregiver's experience. Next. And yes, long COVID does exist in children. And infants born to women who had COVID during pregnancy, some research is showing that they were more likely to be diagnosed with a neurodevelopmental delay in the first year after birth. Now, we know how exhausting and confusing and challenging the first year of an infant's life can be. And now, if on top of that, you're dealing with neurodevelopmental delays and the burden of grief and guilt that the parents might feel, you can see how this also becomes very challenging and disruptive for families. Next. Next. Yeah. So even people who were diagnosed with mild COVID were more likely than uninfected patients to have some symptoms associated with post-COVID-19 conditions. Next. And the excess risk were, different for different symptoms. Next, and I'm going through this a little quickly because I want to actually get to the next slide, where in this particular study, the differences were higher in the first month to 6 months and subsided 6 months to 12 months later. And this particular study, as it was presented in the media, really caused quite a bit of consternation. Next slide. But the next 2 days later, there was another study that was published online, and it had this paragraph conclusion that patients with mild COVID are at risk for a small number of health outcomes, most of which are resolved within a year from diagnosis. And again, you can see that this one probably, if read, evokes much less worry and concern than that first study, which causes more alarm. So sometimes it isn't even that the findings are that different, but it's how the findings are presented. And of course, this also has an impact on the people with COVID, long COVID, and their family members. Next. The percentage of people currently with developing long COVID is declining, thank goodness. Next. And the number of people with non-significant activity limitations is now a little bit more than half, which is, good news. Next. And this is a very large multi-facility program of research called Recover, researching COVID to enhance recovery. And we're all hoping that they come up with some really useful guidelines for people who are struggling with long COVID. Next. So what does it mean to witness someone who's sick with COVID or long COVID? And I mean that question, whether you're a healthcare worker, a friend, a family member, you know, we probably all know someone or we're treating somebody with long COVID. So what does it actually mean? Next slide. Well, here are some of the key symptoms as they impact family life and work life that we're all having to interact with and make sense of and deal with. Brain fog, fatigue, lack of concentration, executive functioning declines, memory problems, difficulty breathing, depression, anxiety. And if you think about that, any of those, again, can elicit sympathy and empathy, frustration, and annoyance. It's not just simply that if somebody has brain fog, you're entirely sympathetic because they forgot to walk the dog and the dog peed on the bed. So there are consequences of living with somebody who has long COVID producing brain fog, which makes them not as functional as they were before, or they forgot to pick up the child at daycare. So these are the kinds of intersections that happen with families.
Dr. Weingarten,
Mhm.
we have a quick question in the chat. Is reoccurring COVID same as long COVID? Will it have the same after effects?
My understanding is that a second COVID infection is not the same thing as long COVID. By reoccurring, if you mean, can a COVID infection kind of you're finished with it, and then a few weeks later you have symptoms of the initial COVID. I'm not aware of that as a category. Next slide.
Thank you.
So now I'm looking at this situation from the perspective of a family member of somebody with, let's just say, somebody who has long COVID. Often, or of course, people want to be in the position of being in that green square. People want to feel effective and competent. They want to feel like, yeah, I'm aware, I know that the person is sick, and you know, I feel empowered. I know what to do. But I think more of the time people are completely aware of the deficits that somebody has with long COVID, but they feel stressed by it and they're exhausted and they just feel ineffective. Like, what am I going to do? Sometimes, you know, unintentionally, people move into that red square and they do things that are, you know, they're just uninformed and they turn out to be misguided or harmful. Or sometimes people are just, family members are like, I just cannot deal with this anymore. And they move into that bottom right square where they kind of abandon the person. And that could happen over a long period of time, or it could just be like one day somebody says, I just can't cope. And they stop paying attention to the person who's sick. Next. So people shift positions. It's not like you're always in the green square or you're always in the yellow square. Depending on the context, you can easily shift position. Next slide. And of course, what we want, people everywhere want to feel that they offer effective action, that what they do is mutually supportive and that it allows people to stay in an intimate connection with the people that they love. But we also know that when you are a witness to somebody who's not well, you just can feel demoralized and despondent yourself. Next slide. Again, you know, a lot of our work in the witnessing, witness to witness W2W program is giving people ideas for how they can move up into that green square to feel more aware and empowered, and not move out of that yellow square where they just feel helpless and demoralized into the other two squares. Next. We know that caregivers often feel demoralized, exhausted, and overwhelmed, and that's common, it's typical, and I think to some extent it's inevitable. Next. One of the other things that we've learned about any chronic illness is that when you are the person who feels ill, that you may experience a sense of self-loss. That is, you live with a painful gap between who you have been and who you are now. And that is really painful for people. But for family members, there is a corresponding experience. Next slide. And that is of ambiguous loss, because the partner may feel, well, you know, the person's there, but they're not who they used to be. And that also is a painful experience. Next slide. The person who's ill and the partner has questions, you know, will I be able to earn a living, or will my partner be able to go back to work? Or will I be able to care for those who depend on me? These are the long-term questions that haunt families. Next slide. And then again, we have the difficulty of getting medical care for long COVID conditions. It requires a lot of work on the part of the patient or the patient's family. People describe it as it's a full-time job, or being an advocate is a full-time job. And people absolutely experience anger and frustration and despair around that are added to the, you know, the burdens of the illness itself.
Dr. Weingarten, we have a question regarding long-term care. So how is the government addressing long-term COVID care?
Well, at the moment, you know, I think they are waiting for the research from the Recover program. There's disability insurance, and that's being adjudicated. There are many more applications for that. The government is going to have to come up with some criteria for that, but this is all at the moment, a moving target. I'm sure that, you know, what's motivating the person's question is knowing that there really do need to be, you know, national standards and programs available, but that really is not happening yet. So again, and the person's question is about this, it's just very difficult to get care. Next. So what can the partner do? There are some things that a partner can do, and that as a provider, we would recommend that you tell partners of people with COVID and long COVID. And the first is be a good listener. The second, and believe it or not, there's quite a lot of very good research. The idea that a partner says, we are in this together. You are not alone. That making it a we and not a you experience does seem to make a positive difference. We have to be advocates with a healthcare system that's doing its best, but is not there yet. is not built out yet to handle long COVID. The research shows that after a year, the vast majority of people will feel better. And so we have to remember that. And then finally, we really want to encourage all family members to take on a healthy or a healthier lifestyle, because that seems to cut the risk of long COVID in half. Next. So what is a healthy lifestyle? Of course, all of you know this. And it looks like if you have 5 of these 6 factors, you would have half the risk of post-COVID or long COVID. Never smoking, or quitting smoking, or smoking a lot less. Moderate your alcohol intake, good sleep, regular exercise, weight control. Next. Social support. So pretty much every one of us is going to know somebody with long COVID, if there are going to be 60 million or 1 in 6 Americans. Next. And what we know is that the more support a person has, the better they cope. But it's a cycle, because the better a person copes, the more likely they are to receive social support. And that's just a sort of a normal human response. We want to help people who it's easier to help. Next. Now, we do have issues with interfacing or interacting with the healthcare system. Next. There have been medical errors, and sometimes if a non-COVID related problem occurs because a family member or the person didn't get medical help, but because they were worried about COVID, and then it's finally picked up late or at a later stage, this significantly complicates the illness course emotionally and relationally, both for the person who's ill and for the family members, because there can be anger, remorse, regret, and guilt. Next. So I did say I was going to say something about vaccines, because as we know, vaccines is a point of conflict for families. Next. There can be conflicts around visiting and holidays, like, does a family agree on what's necessary to protect vulnerable members? Do they even agree to share their vaccine status? And sometimes, as this kind of picture shows, families cut off other people when they have really divergent understandings around vaccines. Next slide. So let's just go through some helpful practices. We talk a lot about hope, but we really think about hope as something we do with others. Next. And here's something that's pretty new in terms of a research basis, but pretty old in terms of what people understand about the important protective value of spiritual and religious community participation. So there is really now very solid evidence for the association between community participation in spiritual and religious practice and improved mental health. And of course, as a healthcare provider, we always have to be sensitive to the individual beliefs and preferences of the people that we work with. But when we learn that somebody is an active participant in a spiritual or religious community practice, we really can support that. Next. And for the healthcare worker, we say, you know, if you've never had a really bad experience of your own of COVID, you might have had a really bad experience of the flu. And if you have an embodied memory of that, that can be helpful, because that's often what people compare it to when they have had COVID or even long COVID. Next. For a moment, not for hours and not for days, but let yourself just deeply touch in to the terror of mortality and the experience of pain, because that really is a context for people who are suffering with COVID, long COVID, and the experience that family members have, that they're aware of that. And these, allowing yourself to just tap into that, and again, not for hours, but for a moment, will provide you a foundation to have more empathy for the people you see. Next. In practice embodied listening and cultural humility. We can't know everything. Next. We want to be sure that you're building resources around your empathic distress. Next. We want to be sure that you're building resources of self-compassion. I mean, there's some things you cannot know because it's not knowable yet. And so we really have to be able to be kind to ourselves. Next. And then, as ever, we need to build up the muscle for tolerating our own grief. Some of the people we work with are not going to do well, and some of them are going to die. So we need to build up that muscle of tolerating our own grief. Next. With families, help them think about reasonable hope, and hope is something they can do with others. Next. You can help them identify their witness position and listen for self-loss, other loss, and point that out. You could say, yeah, I know you just don't feel like yourself anymore, and that's really hard. Consider that they may be grappling with trauma. And of course, encouraging them to accept support from family members and community members, their neighbors, is really important. We want to be sturdy in relation to their grief. And, you know, they might have feelings about their medical team, and we would want to help them be able to share that with you so that relationship can be as smooth as possible. So I think Martha is going to come on and share with you how you can do the post-session evaluation. We have enjoyed talking with you today, and we'll be sending out these materials. And of course, as ever, very interested in your thoughts about how helpful or useful this has been to you. Thank you.
Thank you, Dr. Weingarten, for the presentation. Wonderful information. Please remember to go ahead and fill out the post-session evaluation. This is a requirement if you would like to receive a certificate of continuing nursing or medical education, or a certificate of attendance. Later on today, you will all be receiving a follow-up email from myself with the links to the evaluations, both English and Spanish, the links to the recordings, both English and Spanish, as well as the PDFs of both the English and Spanish PowerPoint presentations. Once again, thank you everybody for joining us. Please remember to fill out the evaluation. It will open again in a different tab once the presentation has ended. And again, thank you to Dr. Weingarten. Special thanks to our interpreters. We appreciate what you do, and we realize it's very hard, so thank you so much for that. And again, thank you everyone, and we look forward to seeing you at another one of Migrant Clinicians Network's webinars. Have a wonderful day, everybody.